Good afternoon, everyone, and Happy New Year. I hope everyone had a wonderful and safe holiday season. We're really excited to be here with you all for our first Facebook Live event, 2021. So, my name is Nilofar Kazi. I'm the Director of Education here at the Center for Innovative Human. Today, we're going to really just go in depth on CIGC's patient advocacy program, kind of walk through the step-by-step process, and we'll be giving insight on how to navigate your GYN and essentially how to be your own advocate as a patient. And then towards the end, we're going to go over some of the frequently asked questions that we receive from patients. Joining me today is Mimi Zaw-Pham, our patient relations manager here at CIGC. Mimi leads a team of patient advocacy coordinators who are the first point of contact for new patients. Through a seamless process, her team establishes the relationship between new patients and the practice. Mimi works closely with physicians, office staff, and the marketing department to develop scalable direct-to-patient programs, including our very successful travel program, which allows her team to connect with women around the world with laparoscopic GYN specialists. Thanks for joining us.
Hi, everyone.
And also we have Abayomi. Abayomi is a board-certified nurse practitioner specializing in women's health. She holds a bachelor's and master's degree in nursing from the University of Pennsylvania School of Nursing. For over 10 years, she's been providing risk and routine obstetrical, postpartum, and gynecological care at several practices across the DMV area. Welcome back, Abayomi. We've had together before. So we've got some topics from people with questions, both Mimi and Abayomi here for patients on a daily basis. If you have other questions, be sure to submit them in the comments and we'll do our best to get to them as we can as we go through the live. So Mimi, to get started, could you go over the initial process for new patients who are interested in finding out more about CIGC and the services we provide?
Yeah, so my team, we assist patients through booking a consultation. We provide information to patients regarding our physicians, our process, going from anything from the medical documents that they would need, the insurance information. We verify their insurance information. We can, once, they meet with the physicians and once they're ready to move forward with the procedure, we also financial counsel our patients so that they can use, they're able to use their insurance benefits to the fullest. So we want to make sure that, we're pretty much helping through the process from the beginning through the end.
Got it. And could you tell us a little bit about, so what are patient relations coordinators?
I'm sorry?
So what are patient relations coordinators at CIGC?
Of course. So we are the first team of, people that our patients would speak to once they call our 800 line. So we will be the first point of contact for the patients. We answer any of the questions regarding our practice, our physicians, our procedures, any, questions that they may have. So most of the time our patients are calling just to make sure that, we will be the right fit for their care. Also, another concerns that they have is their insurance concerns. So we're pretty much walking them through the process and making sure also, when they're, asking us questions about, what documents are needed for their care for the initial consultation, we're able to provide them with the list of documents that they may need, any assistance they would need for the process.
Got it. So basically, with our patient advocacy program, patients you guys are you serve as a support system for patients along the way.
Yeah, so we, we really get to know our patients, and we become, some of our patients become our friends throughout the process, because it doesn't end with just setting up a consultations. If they have any follow-up questions, even after the consultation with our doctors regarding the procedures that they're scheduling, any, questions concerning even the post-op care, we're able to, we don't necessarily assist them with the post-op care, but we're able to connect them with the team that can assist them. So we're always there for them anytime that they have questions throughout the process, even over the phone or, emailing us. Like, we're able to pretty much answer them in real time.
That's awesome. So Abayomi, one of the main concerns we know that comes up is this aspect of the fear of the unknown when patients are planning their GYN care and then considering going through surgery. Could you talk to us a little bit about how you address those concerns in your patients?
So initially, I think when patients kind of present to the practice, they may have some questions as to whether surgery is even appropriate for them. So the first step, really, once you've kind of become aware of the practice, is to have that consultation, right? And so the purpose of the consultation is not to say, oh, you're absolutely going to need surgery, or this is what you have to do. It's really information gathering. So these are my issues as a patient. This is what I'm concerned with as a patient. And are we the appropriate facility to address and remedy those concerns that you have as a patient? Is that medical, right? So is it therapeutics that we could recommend that you might want to consider for management of your issue? Is it surgery? Possibly, we're a surgical practice. But really, it's where the patient comes and they say, these are what I'm worried about. Can you help me? And then as a facility, we say, well, this is what we do. These are the options for you. And then you as the patient then decide the best course for yourself based on that information.
Right. I like that. So this initial consultation, even though we are a surgical practice, as you mentioned, it's not an automatic commitment to surgery. It's more like you just said, it's an information gathering.
Yeah.
How about you, Mimi? So when you're kind of the first point of contact for these patients, how do you address that fear of unknown during that initial consultation?
So we explain to the patient that, once they see our doctors for a consultation, this is not just like Abayomi said, this is not, you're not signing up for a surgery. This is just a planning and discovery session where during the consultation, the physician will address the patient and then, review their medical records to make sure that, we are, they're all on the same page. And then also they can come up with the recommended treatment and options. And also explain to them the pros and the cons and the desired outcomes. So this is, like I said, it's basically a planning and discovery session. So the patients are, they can make the educated, I would say, final decision on what they want to do regarding their medical conditions and issues.
Absolutely. So my question to you is, during this initial phone consultation, I'm sure you come across patients who kind of have done their research through, and you used this term before, Dr. Google.
Yes.
And they come with oftentimes this misinformation. How do you tackle that initial phone?
So yes, the Dr. Google is the dangerous thing sometimes. So, our patients, when they are, so to say for our patients with conditions, our fibroids conditions, so they Google fibroids treatments, and the first thing that will come up is you are, no matter how old you are, no matter what the size of fibroids, they're basically are telling, the first thing that you see is a hysterectomy, and it usually is the open hysterectomy. That's the only thing that you can do. You have no other option. So, and then followed by like pictures. So by the time our patients get to us, they're afraid. And, there are a lot of misinformation out there where, fibroids, most of the time fibroids are not cancerous, but, there are myths about, it is going to be cancer, like this is the, end of it. So hysterectomy is the only thing that, are going to solve the problems, right? So, but some of our patients, they're still, they still want to have families. This is not the information that they want to see when they're Googling. So when they come to us, we try to explain to them, hey, what you see on the Google, Dr. Google is not the be all end all for all patients. So you have options. You need to make sure that you are, you're educating yourself, and also you're seeking out second, third opinions, so that you're aware of your conditions and you're not, freaking out about it. Because that, as women, we, the first thing that we see is hysterectomy, and we are scared, and especially open surgery. So we have to, so we're educating them about our techniques and what our physicians do, so that they, and then making sure that, you have other options out there. So we're basically just making sure that they're not afraid to come to us. And this is just, so that we can speak to our doctors and be really aware of,
you're giving them information they necessarily like from Dr. Google, and you're giving them all the tools they need to essentially be their own advocate and decide for themselves, right? So I'm sure in that initial phone consult or phone communication with you or you, Abayomi, this is more directed to you, Abayomi. When patients come to you in the beginning, I know with fibroids and endometriosis and oftentimes adenomyosis, there's a lot of overlap of symptoms. Patients may think that we're coming in with one condition based on what we researched online. But could you talk to us a little bit about overlap of symptoms between these conditions, and how we often, as women, other secondary conditions we may have?
So part of the evaluation or the consultation is kind of coming up with a differential of what likely is the reason why the woman is experiencing the symptoms that's driving her to come in and seek care. So our plan of attack, so to speak, our strategy is based on those symptoms. So a patient that comes, perhaps she thinks she has fibroids. This is pretty common. Patients will come in and they may be having heavy periods, they're having painful periods, and they might have family members or friends who have fibroids. And so they say, oh, I've got these symptoms. They may have Googled, and Google will say, worst case scenario, you have cancer. It's usually not cancer. But then they may have come up with the diagnosis like, oh, I'm pretty sure I have fibroids. And that may be true, but there's also a condition called adenomyosis, where you have endometrial tissue in the muscle of the uterus. And those symptoms can very oftentimes mimic fibroids. So there's imaging that we can do to kind of discern what it is. But ultimately, not until we've gotten the pathology back from the surgery do we actually get an official diagnosis, a formal diagnosis of fibroids or adeno, and the conditions are not mutually exclusive. You can have both. And sometimes that's a surprise for the patients because they thought, oh, I only have this one issue, and it's no, you have fibroids and you have adeno. And so then it's, how do we manage that going forward?
And to add to that, in terms of, like, for example, last year, our research team published an abstract on the coexistence of fibroids along with endometriosis. So we looked at a total of 327 cases of myomectomy, all patients who went in for myomectomy fibroids. These patients didn't know that they had endometriosis. And then after looking at the pathology report, we found that 45% of the fibroid cases also were diagnosed with endometriosis.
Mm-hmm.
So like you said, if you have fibroids in your care, you may also unknowingly be dealing for a secondary condition you may not know you have.
Mm-hmm.
And also last year, just to add to that, last year, if we put figure 2 on the screen, our research team launched a women's health survey. And the purpose of the survey was to explore and kind of understand the patient decision-making process and the management of their gynecological conditions. And one factor we looked at was the delay in care. When we asked the respondents who had fibroids, we asked them, how long did you have symptoms before you were diagnosed with fibroids? And close to 60% said they waited 0 to 3 years. But what was concerning was that 15% of respondents indicated that they waited more than 10 years before they were diagnosed with fibroids. So you're waiting 10 years, experiencing all these debilitating symptoms before you're actually going to be diagnosed. And then to add to that, 47% of respondents who had fibroids, they were under the age of 45 years old, and they indicated that their diagnosing doctor recommended this watch and wait. And of those respondents, so during this watch and wait approach, obviously you're not taking any action, no surgery, you're just kind of waiting out to see how your fibroids progress or not. And of those respondents, close to 80% indicated their symptoms got worse because of watch and wait period. And watch and wait period essentially is a delay in care. And when we asked the same question to respondents who had endometriosis, how long did they have symptoms before they were diagnosed? What was alarming was that close to 30% indicated they waited more than 10 years. So conditions like fibroids and endometriosis, especially for fertility patients, time is truly of the essence. And one of the reasons women may delay necessary surgery is because they may have been told an open or abdominal surgery is their only option, which is not true. Women with a high BMI may have been told that they're not a candidate for laparoscopic surgery, or may not even have presented it as an option. But if they knew about minimally invasive procedures and the fact that they are a candidate, then they may not delay that care. So just to be clear, minimally invasive options are possible for all women, regardless of your shape, your size. And I actually want to pose this question to our audience. Sorry, there's something wrong with my audio. I want to pose this question to our audience. When considering treatment for your GYN condition, what is your biggest obstacle or hurdle? Now, we know a lot of our potential patients have questions related to finances and insurance. So, Mimi, could you tell us in that initial conversation, how do you as a patient advocate help them to better understand this process?
Of course. So once, when we when we're speaking with their patients after they have so we verify, our team send the insurance information over to our billing department, verification department, to make sure to verify the insurance, to make sure that the patient has a coverage for the initial consultation, as well as a potential future surgical procedures if they were to have procedures with us. So one would know whether they would have a coverage with our center and our also our physicians before they even see the physicians. We verify all that so that they're everyone is going into the consultation knowing what the insurance benefits are. Then after the consultation, our patients decide to move forward with the procedures that our physicians are recommending, and once they speak with our surgical schedulers, or sometimes even before that, if they want to speak to us regarding what their estimated out-of-pocket cost may be, we can definitely speak with them regarding what their benefit package is like, including the deductible, co-insurance, so that they can understand and better prepare for what they're looking at. So none of our patients are going into surgeries not knowing how much they're looking at for the surgeries, because some patients think, there's a myth out there, especially for endometriosis patients. A lot of patients think their insurance is not going to cover endometriosis. That is not the case. So, a lot of insurances will, we will bill for the patients, on behalf of the patients, for the surgery. So there are a lot of it's not all like cash based, because there is a myth out there that endometriosis, the only time that you can get the surgery is the cash based surgery. That is not true. They can definitely utilize their insurance benefits, but we will check all of that, because of course there's going to be some plans that will not cover any surgical procedures. There are also the limitations, all of that. We, verify all of that so that they have a clear understanding of what they're looking at.
Thank you, Mimi. I know insurance and the financial aspect of surgery and preparing for surgery is so nerve-wracking for so many patients.
It is.
Just in general. So it's really comforting to know that you have a team by your side every step of the way.
So we have a great financial billing team that would verify on behalf of the patient. Also, we send the claims to the insurance on behalf of the patient. We obtain prior authorizations for the procedures. So we handle all of that from our end.
Great. Thank you, Mimi. So now I want to jump into some of the frequently asked questions. And Abayomi, I'm sure some of the questions patients ask are really very dependent on their condition, but could you tell us some of the most frequently asked questions you get for a condition like endometriosis? Or what should patients be asking if they think they have a condition like endometriosis?
So commonly asked questions, patients want to know what is normal with regards to pain following a surgery. Of course, everyone's pain threshold is different, but the goal of postoperative pain medication is so that you can rest comfortably. You're having a surgery and it's minimally invasive, but it's still a major surgical procedure. So the pain medication should keep you comfortable. You should be able to walk around, albeit slowly. You should be able to use the bathroom and not have a significant amount of discomfort doing those things. If you take pain medication postoperatively and it's not relieving your pain, then that's something that we should be made aware of. Patients also want to know what their likely downtime is going to be. So again, everyone's recovery is different, but at about 2 weeks, most patients should be feeling probably about 80% back to normal. So they can walk slowly up and down stairs. They shouldn't be requiring a significant amount of pain medication, maybe ibuprofen, maybe Tylenol here and there. But for the most part, you should be able to get by without having to do too much. Still no heavy lifting. Patients also want to know that their course is normal. So I think this is where Google comes in, or talking with girlfriends who have had similar surgeries. And if you talk with your friend, or Google says, well, on day 7, you should be able to do 5 cartwheels. I'm being facetious here. But if they can't do any cartwheels, then usually we'll get the phone call, I can't do any cartwheels. What's wrong with me? Nothing's wrong with me. I don't expect you to be able to do cartwheels. And then that kind of calms things down. So don't compare your recovery, just like you don't compare your your health or your health experience to anyone. Don't compare your recovery to anyone. Just recognize that it is a healing process and it is a process. And what happens for you on day 4 may be very different than what happens to someone else on day 4. So.
Great. So how about, did you touch on, because my connection's going in and out, did you touch on hormonal contraceptives?
No.
Okay.
So if you're taking hormonal contraceptives prior to the surgery, then we usually would recommend that you continue those unless you're doing the surgery for fertility purposes. Depending on what your condition is, speaking generally, we don't usually want you to try to get pregnant in the immediate, I'd say at least a month or 2 following your surgery, whatever that is. And depending on if you have like a myomectomy, we may recommend that you wait a longer time to give the uterus time to heal. And during that time, that's where a hormonal birth control pill would usually be prescribed because it's quick to initiate. When you decide, now I'm going to try, whether that's with assisted reproductive technologies or trying on your own to conceive, you can stop and you have a rapid return to fertility after discontinuing. So in those instances, usually, yes, we would recommend a birth control pill. For patients that have endometriosis and don't have contraindications, we use combined hormonal birth control pills to suppress after we've kind of removed as much disease as it's possible. And that kind of helps to reduce patient pain and symptoms associated with endometriosis. So that's kind of the role of contraceptives in a quick snippet.
Got it. Now, what about the role of, and the questions that you receive on exercise and diet and just overall lifestyle changes?
Diet as far as like just general like things to avoid after surgery, or diet as far as like your lifestyle changes going forward?
Yeah, like lifestyle change. Do patients ask you what if I change my eating habits or if I exercise more, will that impact my condition? And now, since the launch of our wellness center last September, do patients ask how the wellness center can assist in their recovery, or even prior to surgery if they're contemplating surgery?
So with regards to the Wellness Center, I think the Wellness Center is a great resource for patients. There's behavioral therapy, there's acupuncture, there's pelvic floor physical therapists, and there are nutritionists available to patients. So you can have your surgery or whatever procedure is deemed necessary, and then you have access to those specialists to kind of help craft an individualized plan for what would be beneficial for you managing your condition going for like beyond surgery. So after a consultation with Dr. Danilians, then you can kind of craft that plan. And so I think that's helpful. With regards to diet and lifestyle and exercise, I have this conversation a lot with patients post-operatively, typically because lots of patients want to do things naturally or holistically. And that's fine, right? But there is a place for medication in trying to alleviate some of the symptoms, especially if they're chronic. Like if you have adenomyosis, if you have endometriosis, this is something that you have to deal with for a long time. And it's not just going to be, I had surgery and I don't have to worry about this ever being an issue. So your diet is important for your overall health, but your diet is not going to be the solution to managing your endometriosis. And so as long as patients have that understanding that this is something that can help, but this is not curative, then I think diet changes are wonderful. And I will always tell patients, you should eat more vegetables and more fruit and avoid processed foods and try to limit your sugar intake and try to avoid fried foods. And you should drink more water and you should be exercising on a regular basis and you should maintain a healthy body weight or seek to achieve one if you are overweight.
Right.
That's important for your total health and your complete well-being mentally and physically. So it's never going to be detrimental. It's never going to hurt to do those things, but just understand that that's not going to be enough.
And it's not serving as a cure, as you said before.
Right. But it can certainly help. And it's definitely not going to hurt. So it's a wonderful, wonderful thing.
Absolutely. We have a comment from Maria. She's saying a lot of women in the adenomyosis fighters group who are young, in their 20s and 30s, are being told by their doctors that they shouldn't have a hysterectomy due to their age, even though other treatments have failed. Would you comment on this? What is your view regarding hysterectomy and age of patients? And I would direct that comment to you, Abayomi. But before you answer that, just to add to that, for patients with a condition like fibroids or adenomyosis who are planning to move forward with a hysterectomy, if you can also touch on what questions they ask. But let's address Maria's question first.
Okay, so first, I know that there are providers that are reluctant to do hysterectomies or what we consider to be definitive surgery on women who are under a certain age. Mm. We don't operate in that way. Our surgeons take the position that generally, if a woman has come to the decision for herself, or in the case of patients who are trans, if they have come to the decision that they want to have a hysterectomy, of course, we will make it clear to them that this is not a reversible procedure. First, because some patients have been told that it could be. So understand the finality of a hysterectomy. But we don't say, no, you because you're 21, you can't make that decision and we're not going to do the surgery for you. So we don't operate in that way. That's first. So back to Maria's question. First, if you have decided for yourself that your adenomyosis is troublesome enough to you that you are interested in definitive surgery, then we will have a consultation and we can discuss that. And if that ultimately is the plan that we come up with, then that is fine, period. Adenomyosis is a tricky thing. Definitive surgery is the only treatment for adenomyosis. You can't go and carve out adenomyosis from a uterus and retain much of a uterus. And so that's why you can't approach it in the same way as you would fibroids. So patients first have to have that understanding of that nuance. The other thing to be aware of if you have adenomyosis is it can impact your fertility. So your ability to conceive, your ability to carry to term can be impacted if you have that diagnosis. If you want to have children and you want to attempt to carry yourself and you have adenomyosis, then you have to talk about that with your providers to see if that's really viable for you. And so some doctors will not want to take away that possibility by saying you have adenomyosis, you have to have a hysterectomy. I'm very sorry. So I think that's where the disconnect might be between the patient and the provider. So again, it's a conversation. Like, what are your goals as a patient? Do you want to have children? Have you ever had any children? That's very different than a woman that's coming to you and she may have had her children, or she's decided she doesn't want to have children, or she's fine with adopting, or she has the resources to do surrogacy or something like that, deciding that she wants to have a hysterectomy. But those are all things that come up in a consultation. And that's individualized.
What about when patients ask you about the role of keeping their ovaries or not, and what difference that would make?
If you keep your ovaries or if you don't, again, will be discussed in the consultation. Generally speaking, if a woman is not menopausal or premenopausal, but say kind of like right there on the edge, like maybe she's 49 or 50 and she started to have menopausal symptoms, then you might say we should remove the ovaries during your hysterectomy. But ultimately, that decision is usually on the patient, right? If she has decided that she'll remove her ovaries along with her uterus when she has her hysterectomy, then there's a conversation about estrogen replacement therapy, because there are benefits for estrogen for that woman to ease her transition into menopause, and protect her bones and help with the tissue around the vagina and the bladder and so forth and so on. Lots of benefits. So usually it's about age. If patients have like a strong history of ovarian or breast cancer, or they know they carry certain mutations, they may also opt to have their ovaries removed at the time of the surgery. For younger women who are having a hysterectomy, those ovaries are still working and they're producing like great hormones that make that woman feel wonderful. Most of the time, no one's going to be trying to take her ovaries. If there are masses on the ovaries, endometriomas, large ovarian cysts, things like that, then sometimes the ovary may have to be removed at the time of surgery. But again, you would know that usually going into the surgery. So it's not going to be a surprise.
So age plays a big role
Age plays a significant role.
Got it. And what about the cervix in terms of pros and cons retaining?
So there's lots of pros and cons about the cervix. The cervix produces lubrication for the vagina, and that's beneficial just in terms of how your vagina feels on a daily basis. It's certainly beneficial for intercourse. So some patients will decide to keep their cervix. The issue was not so much the uterus, but say someone had cervical dysplasia, like cervical abnormalities or precancerous changes, then certainly we would not recommend that you retain your cervix during your surgery, because that's a source of potential cancer development for you. So it always depends. It always depends. I feel like a lawyer.
Yeah, but you're right. It's definitely a case by case situation. But these are some of the frequently asked topics that come up, and I think a big one that comes up too is how soon after surgery can I have sex?
Okay. So just one quick thing about the cervix. Just because you have a hysterectomy doesn't mean you have to have your cervix removed during the hysterectomy. If you don't have your cervix removed, you still need to continue to have pap smears for cervical cancer screening. So that's really, really important for patients to be aware of. Sometimes after a hysterectomy, patients kind of forget that they still have female reproductive parts that need to be examined. So just bear that in mind.
Good point.
How soon after you have a hysterectomy can you have sex? So we usually say 6 to 8 weeks.
Okay.
6 to 8 weeks on average.
Okay. And finally, before we move on, what about do patients come to you with any specific concerns on after the hysterectomy in terms of mental and emotional concerns that they have?
Absolutely. Because usually they've had a friend, or they remember their mother, or someone who was close to them who had a hysterectomy, and they became a unpleasant person. Like that. And so sometimes women have that concern that you're telling me I need to have a hysterectomy, or I agree I need to have a hysterectomy, but I don't want to become an unpleasant person, or I don't want to lose my desire for sex. So that is an educational conversation where you kind of talk with that woman about whether she's going to keep her ovaries, whether she's going to use estrogen replacement therapy if the ovaries are going to be removed.
Right.
Is she retaining her cervix? Is she taking her cervix out? What is sex like for her going into the surgery, right? Is it painful? Is that something that you want to alleviate by having this surgery? And even I think it's also really important for women to consider the fact that sex is not just a physical act, right? So there are the mechanics of sex, but there's also the mental and emotionality component of sex. So if you are afraid, if you are tired, if you are stressed out, sex is really not going to be pleasurable under those circumstances, even if you had a successful surgery and an uneventful post-operative recovery. Right. So those things also need to be a part of the consideration for what sex is like for you after a hysterectomy.
Absolutely. And thank you for answering those. I know it's difficult to kind of keep it general because it's not one size fits all. Every case is going to be truly different, and that really even highlights the importance of the consultation that much more. And so let's move on to our second audience question that I'd like to pose. If you've ever undergone previous surgery, do you feel your doctor adequately prepared you for what to expect? Now, Mimi, I want to turn to you and ask you what do patients need to prepare for that initial consultation they have?
Yes. So one of the questions that we would ask is when we speak to them on the phone, we ask depending on the medical condition, there are a couple of questions that we would ask, including type of imaging, and then any prior testing, imaging, any type of procedures. So it is really important that our patients are disclosing that information to us. Because if our patient had fibroids, just say, fibroids, and if they had prior myomectomies, we would like to know. Our surgeons will like to see those operative reports. These are the questions because they may had an open myomectomy or laparoscopic myomectomies, but our physicians will need those reports so that they can come up with the individualized plan depending on the previous surgical outcomes. Because not every surgery is the same. Just because they had a myomectomy that was sometimes, they would say laparoscopic myomectomy, but still, it is not the same technique that we will use. It would be a completely different. It would be robotic laparoscopic, or it would be mini lap, which is, the incisions are slightly bigger than our incisions, and they may have more incisions. So it's not, like I said, it's not, every surgery is not the same, even if it is the exact same procedure, because there would be a different type of myomectomies. So it is very important that our patients are disclosing that information and also providing us with those, documentation if it's possible. If it's sometimes, if the procedure is like 7-10 years ago, you may not be able to get those medical records. We completely understand, but it is important that our physicians have a comprehensive view and knowledge of your medical history.
Got it. And so during this initial consultation, also once the physicians review the medical records and previous scans, they're also able to determine if the patient needs any other testing that was beneficial prior to surgery, right?
Yes, exactly. So, for adenomyosis, for example, ultrasound, most of the times, once in a while it would pick up, but the best, I would say, imaging would be MRI. If a physician, so our patients would come in to us for endometriosis, fibroids, and our physicians would review their medical records, have a comprehensive talk with the understanding of their conditions. They speak to the patient, they review the charts, and they may suspect sometimes endomyosis. Then they may, send the patient to get a pelvic MRI to confirm. So, or if they suspect something else, and they may ask you to get, hysteroscopy and DNC so that they can evaluate the pelvic cavity and also rule out any type of malignancy.
So really, patients can use this as an opportunity to fully disclose everything that they've been experiencing up until this point, and also to express their concerns and their expectations of outcomes. And physicians use this opportunity to clarify on expectations and outcomes.
Exactly. Yes.
Okay. So what about when patients go through the wellness center? How does that work? Do they go through Dr. D?
Yeah.
And then
so we see Dr. Danilians come in for a consultation, and Dr. Danilians will develop a treatment plan that recommended. So, based on their conditions and their concerns. So she will come up with a wellness plan for them.
Okay. So they can't schedule a consult directly with a pelvic floor physical therapist or a nutritionist. They would have to go through Dr. Danilians first. She's like main foundation point of contact, and then
so individualized wellness plan for that patient, because not two patients are the same. So
okay, and let's address the obvious point that we are in the middle of a pandemic. So how are we dealing with patient consultations mid-pandemic in terms of telemedicine?
Yeah, so we are seeing patients in office, but we do have patients who are very concerned about the pandemic. We're offering telemedicine, we're offering phone consultations, and we can definitely walk them through the process once they call us. Sometimes they express that they don't feel safe coming in for a consultation. However, they really want to speak to a doctor and have their condition taken care of. So we can definitely assist them with the process. It's slightly different from coming in for a consultation. We can, make sure that they have their medical records, all the required documents ahead of time, so that our physicians can review that ahead of time and then can have the consultation over the phone or via telemedicine, so that it's seamless.
Got it. Now, many patients who need surgery may ask how quickly they can get in, or wonder if they can get in at all due to the pandemic. Do they ask, will they be waiting for several months? I know there's a major backlog of surgeries at the hospital right now because of the pandemic. How is that impacting our center? Do patients have to, in fact, wait several months to have surgery?
So we see a lot of our patients who are in great pain. They've been bleeding for like 2 months, but then they can't get in to even see their doctors for a consultation. And once they get in, they're told that they have to wait 6 months. When you've been bleeding for 2 months, you cannot wait 6 months. It's that's not something that you want to hear. So they will give us a call, and they definitely want to know what the timeline is. Usually, we try to be conservative, but usually it's between 2 to 3 weeks right after the consultation. But it's depending on how severe your case is. Also, usually our physicians can go over the timeline during the consultation also. And another thing is that, our surgeries are performed in outpatient surgical settings, so we have a greater flexibility of providing them with the immediate attention if it's needed.
Great.
Yeah.
So, so you said they're not waiting more than 4 to 6 weeks. And
so I would say more like 2 to 3 weeks. And we are surgeons. Our focus is we perform surgeries. So our doctors are not like out there delivering babies, or they're not doing any other things. Our focus is GYN and surgery. So that's the difference between sometimes the OBGYN and our doctors. So,
and I guess they're able to deliver it or perform surgery in that short time period during this pandemic, like you said, because we are an outpatient center.
Yeah.
And I just want to kind of highlight the point that even if you, as a patient, decide not to move forward with treatment with CIGC, the goal of this consultation, the initial consultation, is to really give you the information you need to become your own advocate for your own health.
And can I add one thing? So the reason for sometimes 2 to 3 weeks is we want to make sure that our patients have enough time for pre-op testing, because there may be some medical clearance that they may need to get, blood work that they may need to do. So we want to make sure that we give them enough time to get those things done for the surgery.
Got it. And for the results to come in.
So yes.
Got it. That makes sense. So Maria also has a second question. She's saying, I had a supracervical hysterectomy in 2007. I still had light bleeding after the surgery for several years. Has progress been made where this type of hysterectomy does not result in possible spotting/light bleeding? Does the dual port hysterectomy that we perform at CIGC here prevent this from happening? Abayomi, can you speak?
So if you have a supracervical hysterectomy and you're premenopausal, sometimes you will have cyclical spotting because there's still endometrium present in the cervix. So if you have a supracervical hysterectomy and say you are still having regular menstrual periods prior to that surgery and you're nowhere close to 51, then you might still have some spotting every month around when you would normally experience a period, and that's normal. And dual port is just the surgical technique to be able to remove the uterus during the hysterectomy. Dual port is not going to do anything to the actual cervix.
Got it. Thank you, Abayomi. So we've actually reached the end of our event today, but before we close out, Mimi and Abayomi, do you have any last comments you'd like to share?
I would just say, realize that a consultation is just a consultation. It's an opportunity for you to kind of discuss with the potential surgeon what your concerns are, what your goals are, and to find out if that surgeon is a good match for your goal for yourself. So ask questions, whatever questions you may have, because this is the best time to be able to ask those questions and get an informed answer so that you can make an informed decision. So ask your questions during your consultation and realize that a consultation does not obligate you to surgery.
Thank you, Abayomi. Thank you.
I mean, just advocate for yourself. And, if you ever, don't be afraid to, if you ever have a questions, if you don't know where to begin the process, don't be afraid. Just give us a call. We'll walk you through it. That's our job. You have enough stress going on with everything that is going on, pandemic, kids, work. We want to make this process easy and seamless for you. So just don't be afraid to give us a call, and we will answer any of the questions that you may have to the best of our ability, and make sure that you're taking care of it.
That's great. Thank you, Mimi. Thank you so much both for your time today. And thank you to our viewers for joining us today. We'll have a recap of this event published on our blog next week. Both a written article and a recording will be available at innovativegyn.com/plan-your-care. And before I close out, I just want to remind everyone, since we are starting a new year, we should start it off with overall better health and just overall wellness. Our CIGC Wellness Center was designed with you in mind, women with endometriosis, fibroids, and chronic pelvic pain. Whether you're preparing for your GYN surgery or just looking for a non-surgical approach to manage your symptoms, you'll find that our Wellness Center offers therapies targeted towards your health goals. At our Wellness Center, we offer pain management, pelvic floor physical therapy, physical training, nutrition counseling, and psychotherapy to help you and manage your complex GYN condition. So if you're interested in learning more about our Wellness Center, please visit www.innovativegyn.com/wellness. Thanks so much, guys.
Thank you.
Yeah.
Bye.